Mouth breathing could be a habit. I mean, some kids breathe through the nose, but they are holding open sounds. Or it could be a real blockage of the nasal airway. The easiest and surest way is to place a dental mirror with the patient's nostrils and see if they forget. It's the easiest and the most reliable way. In any case, it is essential to identify the cause of the open mouth. Depending on that, there are different remedies. In this article published in 2018 in BMC Oral Health, the authors asked nasal and mouth breathers to answer a 50 item questionnaire and found 10 questions that were able to discriminate between the two groups. Based on those 10 items, a second questionnaire was created, which was then answered by another nasal breather and mouth breathers. As a result, they found 7 items with high odds ratios. They would be useful for screening mouth breathing. In other words, I think we can diagnose mouth breathing, and I will show you the item in the next slide. 7 items that are useful in discriminating mouth breathers from nose breathers are presence or absence of discomfort when breathing with the lips closed, insufficient lip closure at rest, hypertonicity of the mastoid muscle, tongue protrusion during swallowing, maxillary protrusion, open bite of the anterior teeth, whether or not there is a history of asthma. The more yes items the patient has, the more likely it is that he or she has mouth breathing. Now, if the cause of mouth breathing and lip closure is habitual, then it may be helpful to promote behavioral change and malfunction of the lip. However, at this time, there is no system to review or meta-analysis that shows that behavior modification is effective in improving habitual mouth breathing. What about myofunctional therapy? In 2018, a meta-analysis from Europe on the effectiveness of the myofunctional therapy for MFT. It states that MFT is an effective treatment for patients with mixed dentition. However, it also states that more data needs to be accumulated. In other words, it is not objectively known what is really an effective MFT method. We still have a long way to go to build details. If the cause of mouth breathing is nasal airway obstruction, a tonsillectomy or orthodontic treatment may be indicated. When the nasal airway is visually obstructed, actually almost 90% of these cases are caused by enlarged tonsils. So tonsillectomy is effective. The paper shown here reports an increase in nasal airflow and a decrease in systolic blood pressure after tonsillectomy in mouth breathing treatment. However, socially, especially in Japan, tonsillectomy does not seem to be performed very important. How about in Vietnam? Have you ever heard about the nasal gargling as a treatment for nasal obstruction?
Okay, ready? 1, 2, 3, go. Good. More. 1, 2, 3, go.
The one that deserves the most scientific recognition is a study reported in 2019 by a group at the University of Edinburgh, UK. Strictly speaking, this is a study looking at the efficacy of nasal gargle as a treatment for upper respiratory tract infection. They randomly divided patients with viral colds into two groups, a nasal gargle group with hypertonic saline solution and a control group. Compared to the control group, the nasal gargle group showed 22% shorter duration of illness, 36 less use of over-the-counter drugs, 35 less familial transmission, and faster viral disappearance. On the other hand, lateral cartilage expansion has recently become a hot topic as one way to improve respiratory function and sugar. According to this meta-analysis, lateral cartilage expansion is an effective means of improving nasal breathing by reducing nasal resistance and increasing nasal gap. However, is it sufficient to enlarge the maxilla one? And how should the occlusal condition be constructed after the enlargement? Orthodontic considerations are necessary. As we come to the last section of the first half, I hope I can give you a take-home messages. First, mouth breathing enhances tongue action. That is, the tongue is a respiratory organ. Second, nasal obstruction impairs memory and lung function. In other words, memory is made by nasal breathing. Third, numerous and systemic functions are modulated with mouth breathing. Thus, early treatment is essential. After listening to my lecture, I guess you will not take your mouth at night, even though you are typical. The other, you've got the full picture, why the breathing task matters. I have a question at the very end of the first half. What's wrong with mouth breathing? So in the second half of my lecture, you will first invited to see the impact of respiratory disturbance in general and consequences during age. Then you will understand what pediatric sleep apnea is, why it is so important, and how you will tackle it. After that, let me introduce our recent findings and reasons why early detection and treatment is important, followed by a new perspective, treatment strategy, and conclusive remarks. Although you are familiar with obstructive sleep apnea or OSA in adults, less attention has been paid to children. It has been indicated that there is an association among nasal obstruction, oral breathing, and OSA. So these authors in mid-90s have reported that the patient with complaints of snoring or sleep apnea can easily breathe through the mouth during sleep, and the chronic nasal obstruction may induce OSA. In a more recent publication in the American Journal of Otolaryngology, it was demonstrated that revitalizing nasal patency could improve sleep quality and symptoms of OSA. In other words, the three conditions, nasal obstruction, oral breathing, and OSA are correlated. So if you see a patient who breathes through mouth, you should think about the possibility of nasal obstruction, and even he or she may have OSA. The etiology of respiratory dysfunction, OSA, is different between a child and an adult. The influence of the adipose tissue in the lateral pharyngeal path is one of the main causes in adult OSA, while the hypertrophied adenoids and tonsils are responsible for pediatric OSA. When we consider the effect of adenotonsillectomy, on pediatric OSA, what do we know? What can we explain to the patient and the parents? In the New England Journal of Medicine, there is an article that investigates the effect of adenotonsillectomy in a cohort of 400 children with OSA. The authors found that adenotonsillectomy in early childhood did not significantly improve attention or executive function, which is behavioral and hierarchical function. However, adenotonsillectomy reduces the symptoms and improves the secondary outcomes of behavior, quality of life, and polysomnographic findings. Thus, the favorable effects, evidences of early adenotonsillectomy have been provided. This is where we are. In other words, we should realize that correlation of respiratory dysfunction in early life does have the significant effects in pathological kids. In the meantime, what happens to kids if they have respiratory dysfunction? In humans, it is known that there are two peaks in the occurrence of sleep disorder brain, or SDB, in the life. The second peak of SDB comes steadily in the middle age, mainly due to obesity, while the first one comes during childhood in association with the hypertrophy of the adenoids and tonsils. Look at the representative 5-year kid with OSA. As you see, the patient shows the typical morphological features, including a large mandibular triangle and retroversive mandible. Breeder and colleagues have reported a catch-up growth in infants after treatment of adenotonsillectomy, after treatment of adenotonsillar hypertrophy. Later, Sultan and co-workers have shown that the patient's height was increased in 6 to 12 months after adenotonsillectomy. So these studies have suggested that correction of respiratory dysfunction has favorable effects on the body growth. In the self-evaluation of OSA children with the enlarged adenoids, there was an increase in mandibular canine, a decreased ramus height, and a low tongue position, and a large anterior facial height. However, in 5 years after adenotonsillectomy, there were several significant changes, including a decrease in the mandibular canine, an increase in the ramus height, and normalization of the tongue position. So these indicate that there are favorable effects of adenotonsillectomy on the primary facial growth. When we compare the OSA symptoms between children and adults, what kind of difference do we know? As a matter of fact, there's a difference in arousals as well as obesity. In addition, there's a difference in sleeping position and breathing mode during the day. Moreover, as I mentioned earlier, the major cause of pediatric OSA is adenotonsillar hypertrophy, but not in the adults. Growth retardation is found in children with OSA, and adenotonsillectomy is curative for those patients. So there are many differences between pediatric and adult OSA. That's why I was interested in pediatric OSA during growth period. I just imagine if it's best to then what it's up to. Now, let me go a bit further into pediatric obstructive sleep apnea, or POSA. Obstructive sleep apnea in kids was probably first described over a fat boy named Joe in the Pickwick papers written by Charles Dickens. The Pickwick syndrome, also called obesity hypoventilation syndrome, appears when the killer is obese and has low oxygen levels in the blood. Minimum oxygen saturation, numbers of atoms, and hypopneas are the main parameters for diagnosis of POSA. For example, less than 92% of minimum oxygen saturation is the cutoff for POSA. Also, apnea is defined as the absence of the outflow longer than 10 seconds. Hypopnea is defined as a reduction of the outflow at least 10 seconds. Apnea and hypopnea index, or AHI, is also used for classification of severity of OSA in children, but with different cutoff lines from those in adults. Normal should have AHI smaller than 1, mild should be between 1 and 5, moderate between 5 and 10, and severe over 10. So these numbers are smaller when compared with adult OSA. As I mentioned, when we think about the criteria for diagnosis of POSA, we should refer to AHI. In the meantime, intermittent hypoxia, or IH, is the one of the hallmarks in OSA. Actually, IH leads to disturbances in physiological activities and multi-system mobility. These include cognitive and behavioral deficits, cardiovascular consequences, systemic inflammation, and growth impairment. Growth impairment includes weight and height reduction, and low secretion level of growth hormones. To study the effect of IH on craniofacial function better, we established the experimental animal model to simulate human IH environment. To mimic intermittent hypoxia in human OSA in the animal model is not okay. The schematic illustration on the left is the experimental setup of our animal model, consisting of air compressor, oxygen and nitrogen generators, and gas blender, and so on. Now on your right, you can see the changes in oxygen saturation in a chamber between 4 and 21% with a cycle of 90 seconds. The table below shows the changes in the arterial blood gas concentration in a 7-week overlap. When we started the experiment with the IH animal model some 8 years ago, we were interested in the effect of IH on the breathing route and investigate the change in the nasal cavity in the growing animals. This is our first publication of a series of IH experiments to look at what happens to the nasal cavity in the growing pillar. By using the IH experimental setup, 7-week-old male rats were divided into the experimental group, which was exposed to IH, while the control group, which was exposed to the room air. After 3 weeks, the maxillofacial structures, especially the nasal cavity, were evaluated. We selected the male rats that were in the growing stage of maxillofacial lesion at the start of IH exposure and plan to finish the experiment after the age of pubertal onset. Soft X-rays were taken in the vertical and lateral projections, and then self-analysis was carried out with special consideration of the nasal cavity, as you see in the top. The width indicated by the length between the both sides of M1 was significantly smaller in the IH group than in the control group. On the other hand, there was no significant difference in both the depth and the height of the nasal cavity between the two groups. Micro-CT was used for reconstruction of the nasal cavity, as you see in the top. The cross-section areas of the nasal cavity at the anterior at ANS and the middle regions at E showed a significant difference in the IH group compared with the control group. On the other hand, the cross-section area of the nasal cavity at the posterior region, PNS, was comparable between the two groups. What about the nasal volume? On the left, the volume of the nasal cavity was significantly smaller in the IH group than in the control group. To avoid the possible effects of the systemic growth, body growth, we measured the length of tibia as the indicator of the whole body growth. And on the right, the normalized nasal volume to the length of tibia as a reference of the whole body growth was significantly smaller in the IH group. So these data suggest that IH exposure suppresses growth and development of the nasal cavity and results in the disturbance of nasal breathing. We extended our region of interest into the craniofacial area and published a second paper. In the article, we measured the variables in the maxilla and the mandible, including the conduct. This was also a study to investigate the effect of respiratory dysfunction during growth. These are the representative micro-CT images of the cancerous bone in the conduct. You will notice a higher bone volume density in the IH group in the bottom than in the control group in the top. These findings were accompanied by a significant reduction in the length of the nasal and mandibular bones. Look at these graphs. From the comparison between the two groups, micro-CT analysis demonstrated a significant increase in bone volume density and trabecular number of the conduct in the IH group. Then in the third article published in Frontiers in Physiology, we examined the changes in the biochemical markers associated with the exposure to the IH condition during juvenile and adolescent periods. The region of interest or ROI in the study was alveolar bone profile. What is the alveolar bone profile? The alveolar bone profile is indicated by heavy black line in the left peak, and the PDL is indicated by black outline in the right peak. So each ROI was analyzed with respect to bone mineral density, bone volume per tissue volume, trabecular thickness, and trabecular length. If you think about the alveolar bone profile, you know that it is covered by PDR that is rich in collagen fibers. That PDR promotes the development and maintenance of periodontium. Alkaline phosphatase, or ALP, and bone morphologic protein 2, or BMP2, are both involved in the osteogenesis and osteogenic transformation of the PDR cells. The PDR maintains alveolar bone homeostasis by the actions of ALP and BMP2. You also know that many cytokines are involved in bone metabolism. In this study, we focused on bone hypoxia-induced fracture, or HIP, and the vascular endothelial growth fracture, or VGEF. Why did we focus on those? A recent study provided evidence supporting the view that HIP and VEGF plays an essential role in coupling between angiogenesis and osteogenesis during bone formation and repair. We investigated changes in the bony microstructure of the alveolar bone around the distal roots of the first mandibular bone using micro-CT. As you see here, the IH labs in the bottom seem to have a higher bone volume density than the control labs in the top. Hansen's bone of the alveolar bone profile was statistically compared between the control and IH groups by micro-CT analysis. There was significant increase in the BMD, BB productivity, TBTH, and TB number in the alveolar bone profile of the IH labs when compared with their controls. We also evaluated the relative expression levels of osteogenesis and angiogenesis coupling markers in the PDL by real-time PCR analysis. As you notice, IH significantly increased the messenger RNA level of HIF1 alpha A and PEGL in the PDL. In addition, it was found that relative expression level of ALP and PMP2 messenger RNA was significantly larger in the PDL of the IH animals when compared to the controls. In fact, this was the first report that IH increased bone mineral density in the alveolar bone profile with the upregulation of HIF1 alpha A and BEG gene expression in the PDL cell. We speculated that these molecules are the critical component expressed in the osteoblasts in the HIF pathway and promote vascularization of the bone wall formation. Of course, we need further study to prove this assumption. In the field of osteochondritis, we published the other article in HAO, which reported the differential effect of IH on the broad growing craniofacial tissues. We measured several parameters in the maxillary and mandibular dentitions and found that the maxillary dentition narrowed while the mandibular dentition expanded. Thus, the relative ratio showed a significant discrepancy. This was further confirmed by the enlarged arch angles. Because we speculated the involvement of the tongue in this change, we determined several landmarks of the tongue and measured. The tongue width in the IH group was not significantly increased, but the relative tongue width to the mandibular width showed a significant increase. In our study published in Sleep and Breathing a few years ago, we investigated the pathogenesis of inflammatory mucosal hypertrophy and the epithelial mesenchymal transformation, EMT, in the nasal cavernate under IH growing animals. We found that IH increased the expression of TGF-beta and N-calcium and decreased E-calcium expression in the cavernate mucosa. qPCR analysis demonstrated that IH enhanced the expression of not only the inflammatory markers, but also the EMT markers. Thus, we have speculated IH worsens nasal obstruction. There was an attached comment on the article. The comment says that the nasal dysfunction is not only one of the causes of OSA. It may also be a target organ of damage. Thus, the study seems to be significant and will help further understand the precise nature of relationship between nasal function and OSA, especially during growth. Around that time, I became curious what would happen to the craniofacial region if the body was exposed to IH in early life. Now I'd like to introduce more recent studies from our lab to showcase how serious the effect of IH on cardiovascular growth and the importance of early detection and treatment. It has been widely demonstrated that IH has influences on the systemic and cardiovascular growth. However, nobody knows if IH has effects on growth and the development of the cartilage. So we tried to compare the mandibular and tibial cartilage, whether there is a different effect of IH. It is well known that there are two types of cartilages. One is fiber cartilage, and the other is hyaline cartilage. The former includes the mandibular bone, and the latter does the lip. These two are deeply involved in the determination of the growth direction and increase in the bone length via endochondral ossification. On the other hand, their chondrocytes have different origins and gene expressions. This is a large mandibular bone. You can see several layers from outside, starting with the fibrous layer, proliferative cell layer, maturative cell layer, and hypertrophic cell layer. The mandibular conduct is rich in type 1 collagen, type 2 collagen, and proteoglycans. On the other hand, growth of tibia as other limb bone occurs via the growth plate cartilage. The layer of the growth plate cartilage consists of the resting zone, proliferative zone, and hypertrophic zone. The tibial cartilage is enriched in type 2 collagen and proteoglycans. This is a cartilage study that has been published in scientific reports with a special attention to the age of the animal, which is very young, to simulate the effect of IH on the mandible during the very early stage of life. We used the neonates, 1-week-old rats. They were divided into the control group that were exposed to the mare and the IH group. And after a week, we performed the morphological analysis using cephalometry and microscopy. Sorry for the busy slide, but basically there was a significant reduction in body weight in the IH neonates. However, there was no difference in the tibial length, which is in agreement with the findings in the previous slides. For the morphological changes in cardiovascular growth, the mandibular growth was significantly affected by IH. Why and when the mandible was affected? By microscopic analysis, it was found that IH induced significantly higher bone mineral density and volumetric bone mineral density of the hand. On the other hand, in the tibia, no such significant difference was observed. Sure enough, there was a distinctive change in the thickness of each layer of the condylar head. It was clear that IH, shown in black in the light graphs, reduced the thickness of the maturative layer, while it increased hypertrophic layer thickness of the middle and posterior mandibular cartilage. And as a whole, the total thickness of the condyle was significantly reduced. Furthermore, it was found that there was a distinctive effect on IH on gene expression associated with the chondrocyte and bone metabolism in the mandibular condyle, in the upper lobe, and the tibial and the bottom lobe. In the condylar cartilage, IH upregulated collagen 10 messenger RNA and downregulated TGF-beta, and SOX9 messenger RNA. On the other hand, IH does not have these effects on the tibia growth rate. By the way, IH exposure is known to induce the sympathetic adrenal activation, which contributes to various symptoms, including pulmonary arterial hypertension, myocardial dysfunction, and inflammation. Nevertheless, the role of adrenergic receptors in craniofacial metabolism under IH was unknown. Since beta-2 adrenergic receptors are predominantly expressed in the bone cells, we aim to investigate the role of beta-2 adrenergic receptors in mandibular growth diseases and bone metabolic changes in the growing animals. In the literature, IH exposure is known to increase leptin, that activates beta-2 adrenergic receptors. Beta-2 adrenergic receptors are found in osteoblasts, osteoclasts, and chondrocytes. Previous studies from our lab have shown that IH induces inactivation of mature chondrocytes and activation of hypertrophic chondrocytes. This may induce premature closure of epiphyseal cartilage associated with a decrease of LAMP expression in chondrocytes and an increase in bone mineralism. However, the effect of beta-2 adrenergic receptor blocker in mandibular growth under IH exposure was unknown. Then the research question was, can IH-induced mandibular deficiency be rescued? If so, how? The hypothesis was that leptin beta-2 adrenergic receptor interaction could be involved in mandibular bone growth retardation, and beta-2 adrenergic receptor blocker is efficient to recover from it. So 7-week-old male rats were used. Why 7-week-old? Because the rat conda was in the growing stage. Look at A on the left. We use the same IH condition. In the study, the rats received administration of either a selected beta-2 adrenergic antagonist, which is glucosamine, or saline. There were 4 groups, as you see in B on the right, from the top. First group is the normoxic rats with saline. Second group, IH rats with saline. Third group, normoxic rats with glucosamine. And fourth group, IH rats with glucosamine. The experimental period was 3 weeks. For analysis, we use the soft X-rays and micro-CT to evaluate the structure of the craniofacial lesion. Also, heart rate and blood pressure were recorded, and plasma samples were collected. ELISA-linked immunosorbent assay were used for quantitative evaluation of plasma levels of certain leptin and growth hormones. Finally, histochemical analysis was performed. So this is the treating group staining. You can see in the upper left panel, mandibular cartilage in the normoxic animal was shown. This is a contrast, while thinner cartilage was stained in the mandibular in the IH group in the upper right panel. It seems that cartilage thickness recovered in the bottom right panel, which is IH plus beta-2 adrenergic receptor blocker. LAMP and OPG pulsing cells in the growing mitochondria were detected using immunohistochemistry. So this was to investigate whether the effect of IH and beta-2 adrenergic receptor signaling on both growth, bone growth, were mediated via changes in macro-OPG interaction. You can see that the immunohistochemical staining reveals that number of lung-toxic cells in the cardiac head was significantly decreased in the IH group, whereas recovery was observed in the IH with apexamin group. In contrast, there was no significant differences in the number of APG positive cells among the four groups. So in the left graph, you can see that the plasma leptin level was significantly increased following IH exposure, and it recovered after rituximab administration. Look at the graph on the right. IH increased mandibular, IH decreased mandibular growth, which is a significant change. However, rituximab reduced density with the alteration in bone mineral density in the cardiac head. So these findings reveal that activation of beta-2 adrenergic receptor through leptin signaling during growth may be involved in IH-induced skeletal growth impairment over the night. But it is risked by selective blockage of beta-2 adrenergic receptors. So it is also noted that application of selective beta-2 adrenergic receptor blocker did not show any adverse effect on the immune. All right. In the last 15-20 minutes, let me share with you my current interest in terms of interaction of 3D sort of breathing and craniofacial group. So far, I have talked about the OSA and POSA in kids. Is that it? I mean, do we leave anything behind? Currently, I have a curiosity about the period around birth. I mean, the perinatal period, especially about the effect of maternal sleep disorder breathing in the infants after birth. Indeed, Allen's and Marx summarize this physiology of upper airway obstruction with the developmental aspect. They suggested that upper airway neuromotor tone and reflexes during sleep increase in normal infants and children compared to adults, perhaps as a compensatory response for their relatively narrow airway. They also stated that a compensatory response appeared to be blunted in children with OSA. Australian researchers have studied childhood health and educational outcomes that are related with maternal sleep apnea. In this longitudinal study, they found that maternal apnea significantly increased hospitalizations of the infants in the first year of life and between the first 6 birthdays. They concluded that maternal sleep apnea during pregnancy is associated with poorer childhood health and its impact on developmental and cognitive outcomes warrants further investigation. As such, the effect of maternal OSA on fetal growth is less clear. Kidon and co-workers aim to investigate the effect of maternal OSA on placental growth and function because the placenta is a critical organ for fetal growth and development. From the findings, they infer that maternal OSA is associated with increased placental weight that correlated with OSA severity and craniofacial and neonatal adiposity, independently of maternal BMI. It is well known that smiling is commonly found in pregnancy, especially during the third trimester, and the principal causes of smiling is OSA. On the other hand, In medicine, a special attention has been paid to the concept of developmental origins of health and disease known as DOHA. DOHA is defined as a disease susceptibility in adolescents and adults. Depends on the intrauterine environmental stress. I mean stress before birth. In other words, DOHA proposes that poor developmental experience can provoke increased risk of non-communicable disease in later life. For example, learning disabilities, cardiac dysfunction, and insulin resistance have been already recorded in connection with the concept of DOHA. Recently, Dr. Flores Mio and the team, including Dr. Little, published an interesting study to examine the differences in the mandibular cortical webs, which is called the MCW, among 161 children diagnosed with BOSA. They found that reduction in MCW appeared to be present among children with BOSA or those at risk for BOSA, suggesting potential interaction between mandibular bone development and oral homeostasis and BOSA. Thus, we speculated the possibility of the postnatal effects of respiratory sleep disorder of the mother on the newborns. In a brand new study, the pregnant rats were exposed to IH in the same manner as I described earlier. The other pregnant rats were exposed to the room air. The offsprings of the two groups were raised in the room air until 10 weeks of age, which is equivalent to early teens in humans. When we look at the effect of maternal intermittent hypoxia, there was no significant effect on body weight and tibial length. This suggests that the prenatal IH exposure does not affect systemic growth of the newborn until 10 weeks of age. At 5 weeks after birth, the mandible of the neonates were examined to clarify the prenatal effect of IH exposure. This is male offspring. As you can see in the right, IH during pregnancy induced a significantly smaller mandible, especially in the legs in the newborn males. There is a significant reduction in the posterior mandibular length indicated by COGO and COGR. Then, what about females? Interestingly, IH during pregnancy induced no significant change in the mandible of the newborn females. On the contrary, by micro-CD analysis, as you see in the left, if you measure the thickness of the cortical bone down below the mandibular first molar, the cortical bone was significantly thinner in the IH male offspring at 5 or 10 weeks of age than their counterparts, I mean females. On the other hand, this suggests that difference in the cortical bone thickness was not due to difference in the systemic growth, rather due to prenatal IH exposure, because there was no difference in body weight. In the offspring muscles, there was significant change in the weight of the muscular muscles of the newborn males, not in females. Taken together, prenatal IH may have postnatal effects of newborn, and these may be site-specific and gender-dependent. We, as the orthodontists, have an interest in craniofacial growth, which involves hard and soft tissues. Our research group has also investigated the effect of gestational IH on the muscular function in the newborn. We have published this article 2 years ago This is a prenatal study. In the study, we compare the effect of maternal IH on the two craniofacial muscles, I mean the masseter muscle and the geniohyoid muscle in the male newborn. The geniohyoid muscle shown in top left, running from the hyoid bone to the mandible, pulls the hyoid bone forward to secure upper L. Thus, it is regarded as accessory muscle for respiration. If you look at the right panel, maternal IH exposure induced in the geniohyoid muscle a significant change in the expression level of several proteins, including PGC1A, an indicator of muscle activity, MFN2, an indicator of mitochondrial fusion activity, and FIS1, an indicator of mitochondrial splitting activity. On the other hand, there was no such changes in the masseter muscle, though the muscle fiber type composition is similar to the geniohyoid muscle. So these findings together have given the biological evidence that prenatal IH induces impaired mitochondrial metabolism in the upper airway dilator muscle. This is another prenatal study which investigated the effect of maternal IH on the metabolic function of the four skeletal muscles. These included the diaphragm, tibialis anterior, masseter, and geniohyoid muscles. Metabolic changes in skeletal muscles in response to gestational IH were assessed by analyzing their relative gene expression changes. This figure clearly shows that expression of the several genes involved in glucose metabolism were downregulated, particularly in the diaphragm and tibialis anterior muscle. Moreover, the expression of several genes involved in fatty acid metabolism was also downregulated, particularly in the diaphragm and tibialis anterior muscle. Anyway, what do we think about the treatment strategy for TOSA? Is there a golden standard such as CPAP for TOSA? Indeed, an improvement in AHI and lowest oxygen saturation has been seen in children who underwent RMA. But remember, especially in the short term of 3 years, randomized trials and more studies reporting long-term data would help determine the effect of growth and spontaneous resolution tools. This article published in 2018 confirmed that TOSA has dramatically improved in growing patients with mandibular deficiency when they have been treated with mandibular cancer. In 2019, a meta-analysis identified 10 interventions such as adenotonsillectomy, antimicrobial therapy, steroids, leukotriene receptor antagonists, rapid micelle expansion, and no treatment. The authors concluded that such approach, adenotonsillectomy, was still the most effective intervention than no treatment in terms of effectiveness in AHI reduction. In addition, RME was one of the most effective interventions to improve oxygen saturation. The effectiveness of adenotonsillectomy together with RME and mandibular advancement was supported by a systematic review published a bit later in 2020. Last year, this article has been published. They mentioned that orthodontic appliances could be used as treatment modalities for TOSA by correcting craniofacial abnormalities. And mandibular advancement appliances alone or combined with rapid micelle expansion could reduce the AHI for patients with TOSA. And RME combined with adenotonsillectomy might be associated with benefits for TOSA. Conclusions with a few take-home messages for you. Pediatric OSA is now getting popular in the general public. In the Insider magazine, there was an article that pointed out we have overlooked Forza. They say that it is, of course, a serious disorder that sets off chain reaction and several adverse effects in kids. If you overlook the Forza, the kid may suffer from risk of hypertension in adolescence, or psychiatry advised sex. So, Forza could be a lifelong threatening disorder for the abandoned kids. In the very end of my lecture, I have some messages which I would like to share with you. First, Forza reduces crime ratio and general health problems that jeopardize quality of life for children. Second, respiratory disturbances in the early period of life should be detected and cured. Third, several treatment options have been proposed. However, it is still necessary to obtain more reliable evidence regarding which, when, and how, because the current availability of few studies, and most of them were considered to have a high risk of bias. I hope some of you were not familiar with Forza might have interest in it. And also about Forza prenatal, perinatal OSA. People generally believe that OSA is an intergeneration disorder. But it is a two generations, transgeneration disorder. Orthodontists should save the quality of life of kids because we know it, and we know its consequences and impairment of crime ratio as well as systemic growth. If we consider orthodontics has or should have a broad scope in human health science, we must understand the significance of early treatment, right after birth, and sometimes even before birth. In order to verify the Doha hypothesis, which I mentioned earlier, to validate the impairment of growth and development due to perinatal disturbances, a research team led by myself was formed several years ago. A joint research involved animal experiments and human studies were studied. The collaborative team includes specialists in pediatrics, obstetrics, and gynecology, respiratory medicine, and genomics and epigenomics. I have presented some of the findings today, and I hope to be able to share more interesting results with you in the future. To close my presentation, thank you for the kind attention may not be appropriate. Rather, I would say sweet dreams, hoping that the babies grow up healthy. Thank you so much.
Expanding our knowledge about the dysfunction of breathing. Maybe many times we don't think about the importance of the lungs, of the dysfunction of breathing, the side effects that this dysfunction can have on our body and different parts of the body. So I appreciate very much your insight, and I am sure that this will improve our everyday practice, and maybe also to think about the challenges as you suggested, to have a different role as orthodontist in the next future. Thanks again for your presentation.